Today we are going to discuss the topic amyloidosis. This lecture is exclusively made from the Rook's textbook of dermatology. So for the PG trainees who are following Rook's as a reference book for their training, hopefully this lecture is going to be very beneficial for you guys. So starting with the origin of the disease, it is derived from the Latin word which is amylum. Amylum basically means starch-like, but the amyloidosis are basically amyloids are proteins. But the term is still used for the reference of this disease. And these proteins are deposited in the ECM, extracellular matrix, as the fibrils, amyloid fibrils. These fibrils has very specific characterizations, like they are non-branching, they are linear, and they are antiparallel in a beta configuration. So these are the characteristics of amyloid fibrils. When you talk about the amyloid, these are not amyloid fibrils just that are making the amyloid component, but there are many other things which are forming the part of the amyloid precipitates. That include amyloid P proteins. That also include GAGs, glycosaminoglycans, fibroblast, some metal ions like copper and zinc. And it also contains collagen fibers. So these are all the components of amyloid precipitates. If we classify amyloidosis, it is classified into two groups. One is the acquired, which is non-hereditary, and one is your hereditary. On further subclassification, it is further into localized cutaneous amyloidosis and cutaneous amyloidosis due to systemic diseases. These are the two categories of localized cutaneous and cutaneous amyloidosis due to systemic diseases. Now we are going to discuss it further. In localized cutaneous amyloidosis, there are papular localized cutaneous amyloidosis, macular localized cutaneous amyloidosis, nodular localized cutaneous amyloidosis, and secondary localized cutaneous amyloidosis. These are all the part of primary localized, and this is secondary localized. Papular is also called lichenoid. As the name indicates, in papular lichenoid local cutaneous amyloidosis, there are lichenoid papules. So in differentials, you can take LSE, lichen simplex chronicus, or the hypertrophic LP, all these. Macular amyloidosis present as pigmentation mostly, hyperpigmented patches or macules. So in differentials, you can add post-inflammatory hyperpigmentation or the drug reactions. And nodular localized cutaneous amyloidosis, it is also called tumefactive. Now for the papular and macular, these two are superficial, involving the papillary dermis only. But when we talk about secondary and nodular localized cutaneous amyloidosis, both are deep, involving the whole dermis. So one difference between the nodular and papular macular is the location of the precipitates. It's papillary dermis in the case of papular and macular, and in the case of nodular, it is deep in the dermis. And one thing important to remember is that nodular localized cutaneous amyloidosis can progress into the systemic form. So whenever you see the patient of the nodular localized cutaneous amyloidosis, you have to be very vigilant because it can progress in the systemic form in the 5 to 50% of the cases. So how you diagnose these patients? Mainly you do skin biopsy, but biopsy is not limited to skin only. Now we can also do fat biopsy from the abdominal fat. And next thing is rectal biopsy. There are special stains that are used in the detection of the amyloidosis that are Congo red, thioflavin, and crystal violet and methyl violet. Now the different thing about these stains are the color of the precipitates. Many examiners do use this in the scenario to confuse the candidates. Congo red gives you apple green birefringence. Thioflavin and another stain is alkaline fusion. It gives you light blue color. Crystal violet and methyl violet gives you yellow to green staining. That is mentioned in the textbook. So this is apple green, this is light blue, and this is yellow to green. Talking about pathophysiology of amyloid, the main thing is apoptotic basal keratinocytes. Basal keratinocytes. What these basal keratinocytes do when the apoptosis occurs, they release cytokeratin, mainly cytokeratin 5 that are present in amyloidosis, but 1, 14, and 10 is present in the order in primary localized cutaneous amyloidosis, and 5, 1, 10, and 14 in the secondary localized cutaneous amyloidosis. So the trigger of these basal keratinocytes are basically pruritus in the case of amyloidosis. So pruritus exacerbate the disease, and it is also the main symptom of the disease. Whenever there is a pruritus, there is apoptosis of the basal keratinocytes enhanced, increased cytokeratin production, and the amyloid precipitates are deposited in the dermis. So the trigger of these apoptotic keratinocytes are also transglutaminase 2. Different associations of the different subtypes of amyloidosis. The macular localized cutaneous amyloidosis is associated with MEN2A, M4 macular, M4 MEN2A, and PBC. Nodular localized cutaneous amyloidosis is mainly with autoimmune diseases like Sjögren's syndrome and CREST, diabetes, paraproteinemia. And secondary localized cutaneous amyloidosis is due to some tumors. It includes BCC, SCC, actinic keratosis, solar elastosis. These all changes so due to sun damage. In the case of papular localized cutaneous amyloidosis, it don't have direct association, but it has variants. One is the poikilodermatous and one is the biphasic, in which papular and macular components are present both. So this is the summary of amyloidosis. Hopefully you find it beneficial. This was the localized cutaneous amyloidosis. In next session, we will do systemic cutaneous amyloidosis.